stroke and gain insights from the moderators and the wisdom shared by our course director. And it is my honor to introduce our faculty for today. So let me share my screen. Yeah. So I first welcome Dr. Anshu Rodki sir. Sir is a consultant neurologist at Sir Gangaram Hospital, New Delhi, and professor of neurology at Gangaram Institute of Postgraduate Medicine and Research. Sir is secretary at Delhi Neurological Association from 2021 and onwards. Sir is joint secretary of Association of Neurologists in Clinical Research, Mumbai. He is a coordinator for National Accreditation Board for Hospital and International Organization for Standardization for Neurology. Sir has been principal investigator in more than 24 studies like VitaTop, Profess, etc. He has more than 47 publications in the various reputed national and international journals and presented more than 25 scientific papers at the various conferences. Sir has been guest faculty at many prestigious neurological meetings and conferences. Welcome, Dr. Rodki, sir.
Thank you. Thank you, Dr. Janki, for a kind introduction.
So Then I welcome our first moderator for tonight, Dr. Babarao Darku Patil, sir. Sir is consultant neurologist at Abhyuday Life Care Hospital, Nanded. Sir has completed his GM from prestigious Niemans Institute, Bangalore. He has more than 10 years of experience and areas of interest are general neurology, stroke, and epilepsy. Sir also has multiple publications in various journals. Welcome, Dr. Darku Patil, sir.
Thank you, Dr. Ajay.
Yeah. Then I welcome our first expert speaker for tonight, Dr. Harsha KJ, sir. Sir is stroke specialist and neuroradiologist at Brains Super Speciality Hospital, Bangalore. He has 17 years of experience and expertise in endovascular neurosurgery, interventional neurology, interventional mechanical thrombectomy for stroke, coiling of aneurysm, carotid stenting, etc. Sir has published articles in reputed journals, including a self-audited success of neurointerventional surgery, which appeared in an international journal. Welcome, Dr. Harsha KJ, sir.
Thank you. Thank you for the introduction.
Then I welcome our second expert speaker for tonight, Dr. Sushant Aildasani, sir. Sir is consultant neurologist at Apollo Hospital, Indore. Sir has done MBBS from Grand Medical College and JJ Hospital, and sir has won gold medal during his MD medicine. Sir has done DM neurology from SGPGI, Lucknow. Welcome, Dr. Sushant, sir.
Thank you.
Yeah. So with this short introduction, I would like to hand over this session to our course director for today, Dr. Anshu, sir, for his expert comments and the context setting. Dr. Anshu, sir, over to you.
Good evening. I welcome everybody to this next event of this no thrombosis. And I think we have two very good speakers today. So we'll like to see new cases and learn something more about stroke today. So I think Dr. Harsha, you will be presenting first.
Sure.
Okay, so please go ahead with your case.
Is my screen visible?
Yeah, your screen is visible.
Yeah. So, warm welcome from Brain Super Speciality Hospital. I'm Dr. Harsha. I'm heading stroke and neurointervention team in Brain Super Speciality Hospital in Bangalore. This is about a 64-year-old female who developed a sudden onset left-sided weakness in both upper limbs and lower limbs since 8 a.m. Her NHSS was 14 at the time presentation. She came to our hospital somewhere at 1 hour 45 minutes to 2 hours at that period. And she has a history of generalized weakness since 1 week and cough. And she was diagnosed as pneumonia. And just 3 days before she came to our hospital, chest X-ray was done for pneumonia, which showed mild cardiomegaly. She was taken to the local hospital for pneumonia and she was started on antibiotics. And she was recently diagnosed to have diabetes mellitus and hypertension, and she was on treatment. So CT scan machine installation was going on in our hospital, so we had to shift her to the outside center and get it done and come back. So this is the CT scan which showed right-sided cortical ribbon sign as well as a dot sign, hyperdense dot sign. There is no hyperdense M1 MCA, but definitely one of the M2 branches looks like hyperdense. Otherwise, probably a small chronic old infarct in the right frontal white matter. Otherwise, the rest of the brain looks fine. So aspect score will be 9. And by the time she got done CT scan and came to us, it was about 3 hours. And after reaching back to our hospital, she was thrombolized with tenectase within 15 minutes. So at about 3 hours 15 minutes, the thrombolysis was done. And because it's a large vessel occlusion, NHSS was 14, and it was suggestive of a large vessel occlusion. So we shifted her to cath lab. And this is the initial angiogram, which showed a large clot sitting in one of the major branches. And then I used thromboaspiration using a red 68 catheter. So you can see there is a small stenosis. That's where the clot was. So the clot was successfully aspirated during the third attempt. So it took about 1 hour to complete the procedure from beginning to end. Once the successful recanalization was done, she was shifted to ICU, and she started showing improvement almost instantaneously. You can see the left upper limb power regaining fast. But then her ECG was taken at 2 instances, one at the time of admission and one after the procedure. The one at the time of admission showed atrial fibrillation, whereas the one after procedure, again, we can see all the P waves. So there was a paroxysmal atrial fibrillation going on. Meanwhile, after shifting to ICU, we thought we will get routine investigations along with that echo. She was hemodynamically stable throughout the hospital stay, but little bit odd point was that her BP was perfectly normal, almost 120/80 from the time she presented to us till the end of the procedure. Usually we see a rise in BP during the acute phase as a compensatory mechanism. And if BP falls after thromboaspiration, that's a good indicator. But in her case, BP was completely normal. And it was a little bit odd, but we didn't give much importance because she was hemodynamically stable. But then we got an echo on the same day evening, and it came as a severe pericardial effusion, signs of cardiac tamponade, diastolic RV collapse, dilated IVC, and then good LV systolic function. So this was a kind of suspicion in previous chest X-ray, but we did not give that much importance at that time because we were concentrating only on large acute ischemic stroke. See the chest X-ray done in our hospital after echo was done, and this is a AP view. So the chest X-ray shows cardiomegaly, which is a little bit more than what was present in the previous chest X-ray, which was done 3 days back. This AP view, the spine is more prominent. Definitely little bit overestimation of cardiomegaly is there, but definitely the cardiomegaly is present in this case. But again, throughout the hospital stay, she was hemodynamically stable before the procedure, after the procedure, before thrombolysis, after thrombolysis. In any case, we gave a cardiology consultation, and because our hospital is an exclusive neuro hospital, so we have to shift her to cardiac center where pericardiocentesis was done. Otherwise, she remained stable even throughout the course of the hospital. And at the time of discharge from our hospital, her NHSS was almost 0. Among the indication among the cardiac condition and IV thrombolysis, particularly in acute ischemic stroke. Almost acute MI and recent MI, all of them, the recent guidance says it is reasonable or maybe reasonable to give IV thrombolysis. Even in acute pericarditis, it is considered as maybe reasonable, which is level 2B. There is more tendency to give rather than withhold the IV thrombolysis. In our case, this is a pericardial effusion, probably mild to moderate pre-existing. And when I reviewed the literature, particularly for pericardial effusion, usually the cases reported are after thrombolysis, which was identified. Probably they all developed after thrombolysis. That is mostly hemorrhagic cardiac pericardial effusion progressing to cardiac tamponade. And even in such cases, so after pericardiocentesis, there was a good result. And again, 2 more cases where hemopericardium with cardiac tamponade, again, good result after pericardiocentesis. Based on these case reports and our case report, probably pre-existing mild, moderate pericardial effusion in such cases, maybe current case also, it may be reasonable to give IV thrombolysis. Probably the recommendation, if we follow the recommendation of American Stroke Association evidence, level of evidence, it will be 2B with limited data. Severe pericardial effusion with cardiac tamponade and then developing acute ischemic stroke, no significant data I could find out, but probably it's uncertain, and probably in such cases the importance will be probably tamponade, and maybe close collaboration with the cardiologist may be required. Whereas identification and prompt treatment in any post-thrombolytic period, such pericardial effusion, if a prompt treatment is given, all the cases have shown a favorable outcome. Of course, there may be some literature bias where the patients who didn't do well, they will not be published in the literature. But still, in current case as well as in the current literature review, the level of evidence will be 2B for thrombolysis with whatever the limited data available. So in summary, pericardial effusion as such, whether it's acute pericarditis or pre-existing pericarditis, not a contraindication for thrombolysis and definitely thrombectomy. With whatever the limited data available, we can probably proceed with IV thrombolysis, especially in large acute ischemic strokes where the patient morbidity and mortality will be higher. Thank you.
Thank you. Thank you, Dr. Harsha. Very nice case. Suppose if I take you retrospectively and you knew that the patient was having a cardiac tamponade, would you have gone back and thrombolized the patient and intervened?
Probably yes, but what I would have done is I would have taken help of cardiologist immediately instead of waiting for echo and a longer time.
Yeah, because the first impression once if you see such thing is that is it a complication of thrombolysis? Because that is the first thing that one thinks, this thing happened after thrombolysis. So when they aspirated, did they found any blood inside the pericardium?
Patient hasn't come back yet, so I'm yet to see the patient again. Okay. Maybe more details I will know once they come back.
Okay.
Rasha, what was the cause of pericardial effusion? Was it post-viral or complication of?
No, I still don't know the details. They are yet to come back to me after their pericardial
what can be the mechanism of stroke in this patient? Is it cardioembolic or
looks like cardioembolic because there is a atrial fibrillation recorded throughout the hospital stay. Paroxysmal, it was intermittent.
Carotid Doppler was not. Carotid Doppler?
Yeah, I did an angiogram, so there were no major plaques. Yeah.
Hey. I think
even recent MI is also not. It is relative contraindication. In recent MI also we can give thrombolysis with
Yes.
explain this to the patient's relative.
Patient, yes.
But
And even in MI, if we give thrombolysis, and even if they develop pericardial effusion, hemorrhagic pericardial effusion due to rupture of the muscle, it is said that you can still go ahead with the pericardiocentesis and still the outcome may be reasonably good. So it comes to level 2B evidence. So we may consider giving thrombolysis rather than withholding thrombolysis. That's the current recommendation.
Because previously in MI, in a setting of MI, it was a relative contraindication because
Yes.
of the risk of, I think, the same risk of myocardial rupture.
Yes.
Rupture
Yes.
and hemopericardium. So I think we have to balance and weigh the situation and then take a call.
Yes.
So I think it's a. I think if the patient had pericardial effusion, then it would have become very difficult. I think retrospectively now it was good for the patient that you thrombolize and underwent thrombectomy. So I think anyway she had a very good outcome.
Yes.
Anyway. And thank you for educating us on this this pericardial effusion and this thing. So I think we can move on to the next case, Dr. Sushant.
Yes, sir. Sir, can I start sharing my screen?
Yeah, please go ahead.
Good evening, everyone. At the outset, I would like to thank Emcure Pharmaceuticals for providing me opportunity to present my case. I have presented numerous cases to Dr. Rothgi sir on various platforms. Sir might not be remembering that as a resident, I have presented him. And this case which I'm presenting now, it is one of the first few cases that have come to me as I joined consultant neurologist after completing my DM in Apollo Hospital, Indore. So if I wanted to present this case so that I can come to know anything else which we could have done in this case or any other treatment that could have been given. So this is patient. He's a 58 years male photographer by occupation, known case of systemic hypertension and diabetes mellitus. He is an occasional alcoholic with no other addictions, with BMI of 21 kilogram per meter square, so moderately built with no other comorbidities. So this patient presented with sudden onset, complete painless loss of vision in right eye around 11 a.m. Patient had similar episode 3 days back, which recovered within 30 minutes, and so he did not consult any doctor at that time. So this day, the patient was sitting and having breakfast with his family, and then he suddenly had this painless, complete loss of vision in right eye around 11 a.m. There was no other symptoms such as slurring of speech, weakness, and paresthesias in any limb, headache, jaw claudication, or loss of consciousness. Loss of vision in right eye was complete, and there was not even any perception of light or movement, although he could see properly with the left eye. Patient was immediately rushed to an ophthalmologist who happened to know me, so he called. And as the time was limited, he could not take the photograph of the fundus, but what he told me that there is severe edema and some pallor around retina is there. He suspected that it is something ischemic, we considered, and he referred the patient to us. So ocular massage was given to him by the ophthalmologist and was referred to Apollo Hospitals and was referred to and attended by me around 12 p.m. in ER. So within 1 hour of the onset of stroke, the patient had come to the ER. On examination, patient was conscious, oriented, afebrile with blood pressure of 150/96 with pulse of 80. His RBS was 136. There was no pallor, icterus, clubbing, lymphadenopathy, and edema. On examination, he had RAPD in the right eye. Fundus, what I saw, there was severe edema. I couldn't make out any cherry red spot, and then there were thin blood vessels was there. Right eye, there was no perception of light or perception of movement. Left eye vision was 6/9. Color vision in left eye was normal. There was no extraocular movement abnormality, and other cranial nerves were within normal limit. Motor system examination, patient had normal tone, power. His dependent reflexes were 1+, and both the plantars were flexors. Sensory system was majorly unremarkable, except his Romberg's was positive. Cerebellum examination was normal, and other systems were within normal limits. So we did an CT scan, which was normal. There was no hypertension or any other sign of MCA thrombosis or any clot. We had a bit of time, so we took a liberty of doing his MRI brain also, which showed small acute infarct in right parietal region, but then it doesn't justify his weakness. His MR angio, as we can see, this small acute infarct in right parietal region, but obviously his neurodeficit was not explained by this. His MR angio was done, and as we can see that there is complete occlusion of right ICA just above the bifurcation. And in this we can see even the right MCA and right is A1 and A2 are filled by the communicating blood vessels. So after taking this appropriate consent and explaining the risk to the relative, the patient was thrombolized by using injection tenectase around 0.2 milligram per kg. Around 16 ml was given as bolus. On evening when the patient was evaluated, he had mild conjunctival hemorrhage in the right eye, but there was no improvement on vision. Next day, luckily, patient had some perception of hand movement in the right eye, which on day 3 improved to finger counting at 6 meters. Unfortunately, the vision remained same and did not further improve. The patient was discharged around day 5, and his investigation showed patient had mild dyslipidemia. His HbA1c was 7.5, homocysteine levels were raised, ESR was 18 and CRP was also within normal limits. Carotid Doppler showed 100% stenosis in right ICA just above the bifurcation. There was also par with 30% stenosis with altered velocity in the left ICA. His RNFL was done on day 5, day 6, and it showed that the edema of the retinal layers, which is present initially in such cases. On discharge, the diagnosis of ophthalmic artery thrombosis, probably or its branches such as CRAO, probably due to IC thrombosis, was considered. Patient was given antiplatelets, antioxidants, multivitamin, OH and antihypertensive medicines were continued. Patient returned for follow-up last week, but unfortunately, there was no significant improvement in his vision. So this we considered a case of ophthalmic artery thrombosis, probably due to occlusion of the right ICA. Ophthalmic artery is generally the first branch of the IC which arises after the cavernous segment and which give branches such as central retinal arteries, which supply the central part of the eye as well as the inner retinal layers, whereas the posterior ciliary artery supplies the posterior part of the retina. In patients with CRAO, central retinal artery occlusion, we generally have a cherry red spot as the posterior ciliary artery circulation is present. But in patient with ophthalmic artery thrombosis, where both the central and the posterior ciliary artery, there is no cherry red spot and there is a lot of edema initially, which later leads to atrophy of the retinal layers. Management of ophthalmic artery thrombosis can be conservative for such as ocular massage, anterior chamber paracentesis, or IOP lowering agents. IV thrombolysis in AHA guidelines for stroke thrombolysis, not much has been given about thrombolysis in case of ocular cases, but as we see the definition of the stroke, that is sudden onset focal neurological deficit, probably due to a vascular cause. So even ocular cases fit in the definition of stroke. So thrombolysis should be considered for that. As I was searching the literature, I found this meta-analysis in which total 147 patients were enrolled who were thrombolized in 7 studies, whereas 390 patients from 8 studies with conservative management were taken. IV thrombolysis was beneficial at 4.5 hours or earlier as compared to the patient with natural history of progression of thrombosis group. 17 out of 34 patients, that is 50%, patients had benefit if the thrombolysis was done within 4.4 hours, and the absolute risk reduction ratio was 32.3%, with number needed to treat was 4. There was no significant difference in patients treated after 4.5 hours, showing that late intervention is futile. In non-primate studies, they have shown that in case of ophthalmic artery or CRAA thrombosis, the ischemic damage, the irreversible damage start as early as 105 minutes after the onset of the stroke, and after around 240 minutes, that is after 4 hours, generally the deficit becomes irreversible. There is one more technique of intra-arterial thrombosis, which was given in literature, in which the ophthalmic artery was cannulated through femoral and ICA, and precise dose of thrombolytics could be tailored in real time. However, it is a bit labor intensive and required intervention setup in emergency. Also, complications like catheter-induced spasm or pre-procedural stroke. So this is not a very popular treatment. So this is a small algorithm in which acute painless monocular vision loss. We should examine the patient clinically. NIHS scale score should be done. Basic parameters such as blood pressure, random blood sugar, ESR, CRP to root out giant cell arteritis can be there. Patient should be subjected to CT brain or CT angio or MR if possible. Fundus and quick visual examination should be assessed. And if the patient is in the time frame of less than 4.5 hours from the normal or near normal baseline visual acuity, no other evidence of any giant cell arteritis or contraindication to thrombolysis, patient should be subjected to IV thrombolysis, and post-thrombolysis institutional care should be given. So we've always heard act fast, but in this case, I would say we should act very fast, where we should be for visual, because this monocular visual blindness should be considered as important as the other components of fast, and patient should be subject to thrombolysis. Unfortunately, in our case, patient could not improve much, but still a benefit of thrombolysis should be given. Thank you, everyone.
Thank you, Dr. Srishant. Thank you. Last time also we had a similar patient of CRAO in the last meeting. Can you stop screen sharing?
Yes, sir. Yes. Yes.
Yeah. So last time also we had one similar patient of CRAO. We had also discussed all the options that were available. Now the problem with basically is that most of the time you have a CRAO, central retinal artery obstruction. This is a very small vessel, so intervention is almost ruled out. And giving an IV thrombolysis, we've seen that it doesn't really. We have tried IV thrombolysis previously, and it doesn't really work because vision really doesn't improve. But of course, we need to act fast, because it is believed that I think within 90 minutes, the damage has happened. So I think what is important is that we need to act very fast, as you said, Dr. Srishant. So we have even tried doing a selective this thing previously. Initially, when thrombolysis just came in, but the results are not good. So I think it's a very difficult situation to really handle, because after doing everything, patient doesn't improve. I think we need to create more awareness in ophthalmologists, because what happens is these patients first go to the ophthalmologist, and the ophthalmologists do not realize what is happening, and they keep doing all these massages and paracentesis and all that, and the vision is ultimately lost, and the time window is lost. So I think, Dr. Ajinkya, I will just suggest you that I think you should create more awareness in the ophthalmologist about this ocular stroke. Because what happens is that whenever they have a patient of a similar kind, they refer it to the cardiologist and not to a neurologist. We have seen a lot of times that ophthalmologists, whenever they just send it to the cardiologist. So I think we need to create more awareness about the ocular stroke, and then one can try and give tenecteplase, because I think in this patient at least some vision has come back, and the vision can improve over a period of time. So I think creating awareness is important.
Yeah, sir.
So Dr. Babura, you have something to say?
Sir, can you use some higher dose, like standard recommendation is 0.25 mg per kg. Now recommendation of 10.
Yeah. I think the recommendation has not changed to 0.25. So I think one can do that.
May I comment about this case?
Yeah, Dr. Harsha, please go ahead.
Yeah, so this case very unique, that entire ICA is occluded as against central retinal artery occlusion. And as we know, entire ICA, it's very difficult to open with IV thrombolysis. Usually, the improvement in such cases should come from collaterals from ECA. So which probably in thrombolysis would have helped rather than recanalization of the ICA or ophthalmic artery. It's probably the central retinal artery getting collaterals from ECA. Thrombolysis definitely might have helped, because that would also, the thrombosis, whatever in the ophthalmic artery would have got dissolved. Otherwise, ICA rarely opens with thrombolysis. In your case, it's very unique. So
Yeah,
now
I think this is a very important point. I think because the IC was totally occluded. So I think it was basically because of the collateral. I think the circulation improved.
Yes.
And, because that's so. Did the IC had a thrombus, Dr. Sushant?
Yes, sir. Yes, sir. It had a complete thrombus, complete plaque with stenos with 100%.
Was it a plaque or was it a thrombus? That's
Sir,
what I was trying to ask you. In the Doppler, were they able to see a thrombus or not? Was there a soft thrombus there?
sir, they had mentioned it is a plaque, not a soft thrombus.
So probably it is chronic thrombosis with superadded chronic atherosclerosis with superadded thrombosis. Chronic occlusion probably.
Yeah, I think most likely chronic occlusion because normally we see this actually today only I discharged one patient. He had actually a young patient and he first I had an episode on the day of Holi. He had this episode. He recovered. He didn't go to a doctor. And after 2 days, he had another episode. Now he's left only with tubular vision. So he first went to another hospital and he found that the left ICA was not seen. We did a DSA and ICA was totally occluded. Then we did a Doppler and he had actually an ICA thrombus. He had actually an ICA thrombus.
Sir, I want to ask, sir, this patient also had this similar episode, amaurosis fugax, 3 days back also, which lasted for 30 minutes. And this gentleman also didn't visit to any doctor. So all I want to asking that had this patient come to us that day only with obviously recovered, and when we would have found if there is because this plaque, as we suspected the chronic, it might have been that day also. So that day, could we have intervened or could we have done something to prevent this?
Yeah, maybe I think anticoagulant, we would have started anticoagulants. I think we might have prevented this episode from occurring. So okay. I think CRO is a really is something that awareness is not there. So I think we need to create more and more awareness about this.
Thank you.
Sometimes these patients are maintained on dual antiplatelet. They don't develop TI symptoms. I had a similar patient with chronic IC occlusion and had amaurosis fugax few days back. And after starting dual antiplatelet, she never had such symptoms recurrence. So I think on this patient, they can maintain on dual antiplatelet.
So role of anticoagulants in this with complete ICA thrombus or antiplatelets are sufficient?
Actually, this question we discussed last time also. So if you have a thrombus, I think for short term it is better to use a single antiplatelet with anticoagulants. And if you're not seeing a thrombus there, then I think antiplatelet should suffice. So I think that is so if you're seeing a soft thrombus, because likely the thrombus can go off, I think it is advisable that for a short period of time use anticoagulants and then maybe switch over to antiplatelets. But if you have a complete occlusion without any thrombus, then I think antiplatelets is the way forward.
Thank you, sir.
So are there any other questions, Dr. Ajinkya?
No, sir. Nothing from the audience.
I think we have two can we close the meeting?
Yes, sir.
Thank you. So I think we had two very, very interesting cases. In fact, the first was really an eye-opener because I thought that it was a sort of a contraindication to thrombolize a patient as a pericardial effusion or tamponade. But I think the level of evidence is evidence 2B. So I think that's so one can consider thrombolysis. The other one also was Dr. Sushant tried to open up that vessel, and I think some vision has come back. So I think both of them are very, very difficult situations. And sometimes I think all of us, stroke is such a difficult proposition at times. Every day brings a new challenge. Every day we are learning. Nobody can say that he's a master of stroke because every day is so difficult, so different that we really keep learning. I think I must thank Emcure for bringing me to this platform because every time we see some new cases, we're learning something new. So I think with that, I'll thank my moderator, Dr. Baburao, and Dr. Harsha and Dr. Sushant for bringing some two interesting cases. And I will hand over to the organizers.
Yeah. Thank you so much, sir. So as usual, it was a wonderful workshop. And sir, actually, we are working on a program to increase the stroke awareness in general public. But as suggested by you, sir, we will surely work on increasing the awareness in ophthalmologist as well. So I would like to thank Dr. Harsha sir and Dr. Sushant sir for presenting those interesting cases. And thank you so much, Dr. Rodgi sir and Dr. Darku sir, for your expert comments and great practical insights. We would really like to work under your guidance for many such future programs. So with this short notes, we will close this session. Thank you everyone again. Bye.
Thank you. Good night.
Good night.
Thank you, sir. Good night.
Thank you. Good night.